Despite the availability of evidence-based treatments for patients after acute myocardial infarction, including antithrombotic therapy, antiplatelet therapy, lipid-lowering agents, and newer generations of coronary stents, the risk of a recurrent cardiovascular event remains substantial, particularly in the initial 90-day period after the acute myocardial infarction. Heart attack, people. The presence of multivessel coronary artery disease, diabetes, and other established risk factors is known to exacerbate this risk. Thus, given that the current secondary preventative therapies do not adequately address this residual risk, new therapeutic approaches are needed. This is from the New England Journal. C.M. Gibson et al. 2024. Link in the description. The disruption of atherosclerotic plaque that consists of lipid-laden macrophages and a necrotic core is commonly the primary pathophysiological event in acute myocardial infarction. Reverse cholesterol transport is the mechanism by which excess cholesterol, such as atherosclerotic plaque, is removed from the peripheral tissues and transported to the liver for excretion in the bile. The initial step in reverse cholesterol transport involves cholesterol efflux, which is mediated predominantly by apolipoprotein A1, the main protein in HDL, or high-density lipoproteins. Patients with acute coronary syndromes have an impaired cholesterol efflux capacity, which has been independently associated with a higher incidence of major adverse cardiovascular events, including a higher incidence of both short-term and long-term death from any cause in patients who have had an acute myocardial infarction event. CSL112 is a human plasma-derived apolipoprotein A1 that is formulated with phosphatidylcholine to form disc-shaped particles that are suitable for intravenous infusion. In previous studies, a 6-gram dose of CSL112 resulted in immediate and robust increases in apolipoprotein A1 levels to twice the baseline level and cholesterol efflux capacity to 4 times that of baseline. A dosing regimen of 4 weekly infusions was chosen to maximize exposure, but minimize accumulation in a logistically practical way during the weeks after acute MI. We hypothesized that CSL112 administered weekly for 4 weeks, beginning immediately after the occurrence of acute myocardial infarction, would reduce the risk of myocardial infarction, stroke, and death from cardiovascular causes during the 90-day high-risk period after acute MI. Study population: at least 18 years of age and had type 1 spontaneous MI as defined according to the 4th universal definition. Skip ahead. Key exclusion criteria: evidence of hepatobiliary disease, ongoing hemodynamic instability, LV ejection fraction less than 30%. It looks like they excluded heart failure patients. Endpoints. The primary efficacy endpoint was a composite of myocardial infarction, stroke, or death from cardiovascular causes from the time of randomization through 90 days, assessed in time to first event analysis. Key secondary efficacy endpoints included the total number of hospitalizations for coronary, cerebral, or peripheral ischemia from the time of randomization through 90 days, and a composite MI, stroke, or death from cardiovascular causes from the time of randomization through 180 days and through 365 days, assessed in a time to first event analysis. Multiplicity in testing the primary and key secondary endpoints was addressed with the use of serial gatekeeping, a serial gatekeeping procedure for 3 pre-specified families of null hypotheses to control the overall type 1 error at a two-sided level of 0.05. Let's skip ahead. Patients, a total of 18,848 patients, provided informed consent and underwent screening of these 18,226 patients at 886 sites in 49 countries. Underwent randomization from March 2018 to November 2022 after the exclusion of 7 patients because of concerns with respect to the quality of data at one site. 18,000 patients were included. Okay, so they subtracted some. The baseline characteristics were well balanced between the two treatment groups shown in Table 1. You can click on the link for that. Okay. The percentage of patients with a qualifying STEMI was similar to the percentage with a non-STEMI. Patients were receiving appropriate treatment with guideline-recommended medications. Skip ahead. Major cardiovascular adverse events. There was no significant difference between the two groups in the risk of MI, stroke, or death from cardiovascular causes. Let's skip ahead. Safety outcomes. Discussion. Here we go. Among patients with acute MI and multivessel coronary artery disease who had additional cardiovascular risk factors for weekly infusions of CSL-112 did not result in a lower risk of myocardial infarction, stroke, or death from cardiovascular causes through 90 days than placebo. The efficacy results were consistent across the pre-specified subgroups. Overall, a similar percentage of the patients in the CSL-112 group and the placebo group had adverse events. The number of patients who had hypersensitivity or anaphylactic reactions that resulted in discontinuation of the investigational product was very low, which is consistent with other plasma-derived protein therapies, but the number was higher in the CSL-112 group than the placebo group. A major scientific question that this trial attempted to investigate is whether enhancing HDL function can protect against atherosclerotic disease, or the HDL hypothesis. Our clinical outcomes trial directly tested whether modulating HDL function by enhancing cholesterol efflux capacity with CSL-112 as opposed to attempting to increase HDL cholesterol levels would lead to reductions in major adverse cardiovascular events. On the basis of animal and human data, that showed favorable remodeling of atherosclerotic plaque after infusions of apolipoprotein A1. Our pre-specified hypothesis was that administering these infusions after myocardial infarction would stabilize atherosclerotic plaque and lead to a reduction in the risk of major adverse cardiovascular events. Furthermore, impaired cholesterol efflux capacity has been associated with poorer outcomes after a myocardial infarction. CSL-112 has been shown previously to improve cholesterol efflux capacity in the post-MI context. Although there was no reduction in the incidence of the primary composite endpoint, a positive trend was seen with respect to the individual component of MI. That would be consistent with the proposed biological effect. There was gradual separation of the curves, with a maximal difference in myocardial infarction between the two treatment groups at 6 months, which could be consistent with remodeling and subsequent stabilization of atherosclerotic plaque. Testing the HDL hypothesis in the context of successful implementation of LDL protein lowering therapies is increasingly challenging. The patients in this trial showed excellent adherence to evidence-based and guideline-directed therapies that also included a dual antiplatelet therapy. So why did I bring this up? The guest on today's podcast, Mr. Fred G. He's a healthcare IT data specialist, works at a public health clinic on the East Coast, and Fred has a significant family history of cardiovascular disease, and so cardiovascular disease, coronary artery disease, and cardiomyopathy. He grew up helping his family members deal with this disease, but Fred has remained healthy and active his whole life. He's a rebel against the confines of credentialism, prestige, and status. a self-made professional who carved out a niche helping public health physicians, internal medicine physicians, and family medicine physicians better interpret their clinical data to improve outcomes in their patient demographic. And a lot of their patients have cardiovascular disease. Welcome to this episode of 3 Deeper Cuts, the lifestyle magazine for the practicing surgical pathologist. You know what it is. All right, without further ado, we're going to get right into it. Here we go, Mr. Fred. And here we go. Welcome to the 3 Deeper Cuts podcast. Mr. Fred, thanks for joining us, man. How are you today?
I'm good. Thank you for having me. It's been a couple weeks waiting to get on with you and have this conversation, but I'm looking forward to it, man.
For sure, man. So, what general area do you work in healthcare and in what context?
So I work in public health, specifically in health IT. I've been working in public health, I guess, on and off, about 12, 13 years. I took a little break from the industry just for a little while, and I've been back to it for about a year and a half now.
Got you. Okay. So you're in the public health sector, specifically in IT. How did you get
Correct,
involved in
yes.
that?
Oh, that's okay. So I'd have to take it back and give you, go into
Sure.
story time a little bit here.
Yeah, please.
So around, I want to say 2005-ish, I was a young man in my 20s who was sort of kind of at that crossroads, right? Like I hadn't finished college, wasn't exactly sure what to do, and found myself in a position where I sort of just had to take a random retail job to make ends meet, and was doing that for a little while. And I meet one of my coworkers who tells me about a program where I lived at the time in New York City, where they would train you for medical billing and coding, administration, and medical assistance. It was like a joint program. It was supposed to be for like, it was supposed to be like a community program to sort of get people to work. It was free, and it just required for you to meet certain criteria, which luckily I met. And I went through this program thinking, all right, this is something I can do while I figure, whatever my career path is going to be. I hear, that medical billing and coding is. So originally my idea was to go into administration, because I had a sort of a almost phobia of the, excuse me, of the idea of working in actual like hands-on patient care, just from like things growing up, like my mom having heart disease, my brother having heart disease, and being in and out of hospitals a lot. Just kind of like I would get general anxiety from the idea of working in healthcare. So I figured if I go into medical administration, I don't have to be around any of that. And so I got into this program and I went through the whole thing, and it's like a course where, you go through all the typical stuff of how to work a front office, back office, medical office thing. And then, some of the, light clinical stuff that medical assistants are allowed to do, like the blood work and, the phlebotomy and things like that. End of the program, they send you to a internship, which mine ended up being in Harlem, New York. And the idea is that you just go and you get your experience, and then when you get out, hopefully you get some job placement. And I didn't even get to do any of the administrative stuff. They were like, first you got to start your clinical stuff. So, I show up in scrubs day one. Week one, they have me draw blood for the first time, and I'm instantly hooked on the idea of working in healthcare all of a sudden. Went from phobia to like instantly just like, this is where I want to be somehow. Somehow I'm going to be in healthcare. I just knew at that point, like that was it. And it was something about I don't know what it was, just working in the lab and being methodical, and, there was something about that process that just kind of dove me in. And the fact that I realized that I was actually kind of good at phlebotomy, I was like, maybe there's something to this. Like maybe this is like the avenue that I never explored, never considered, but should have explored.
Nice.
And so lo and behold, kind of like was working with this clinic for like 5-6 years, and back and forth decided, trying to decide whether I would go to medical school or whatever, maybe nursing or whatever it was going to be. And ultimately found myself working in quality improvement and quality assurance with that same clinic. And then an agency within the city sort of found out about me through working with me, and I got poached, and I ended up in public health that way.
Got you. So what types of clinics are you, are you managing like an academic type of situation or?
No, so I work, let's put it like, I work in government. So what I do is I manage a lot of data workflow right now for different programs. It does include a lot of clinical studies, some stuff going on around cardiovascular disease and other things. There's multiple things that like I sort of help. I'm a
Okay.
project manager basically. So whatever
Okay.
projects the agency has going on, I have some part in playing in all of them.
Got it. So it sounds like you're you're able to see the stories that the data is telling you. So what have you picked up in, say, the last 5 years?
Well, not so much in the past five, because the 4 year hiatus I took was within the past 5 years.
Okay.
But since I took a little bit about before and a little bit since I've been back. So before I got into the role that I'm in, I used to sort of be one of the, quote unquote, field workers within what I do, going out to different, whether it be community health centers, mom and pop doctors' offices. And the idea was basically, how can we help engage doctors in these, say, underserved communities to sort of find avenues, whether that be through patient engagement, community, maybe through community engagement or whatever it is. What avenues can we help you improve the outcomes in your patient population, particularly around cardiovascular disease? Obviously, we focus big on hypertension, diabetes management. Though we're starting to kind of go a little bit also into some of the ancillary stuff, like we're tracking retinopathy referrals and things like that. So basically I've gotten to see, just from working hands-on with different, not just my experience working at this one clinic for a few years, but just going around, at the time going around New York City and bouncing around and sort of getting the story direct from doctors. Like, what are the challenges in treating patients in these communities? What are the challenges within payment reform? At the time was like big, right? Like we went from fee for service system to the capitated system, which I'm sure you know about.
Yeah,
And so like all those things. But yeah, we could dive into whatever you
let's
want.
dive into that a little bit more. So what did you see like as that payment system changed where you were working?
So I saw a double-edged sword, honestly. In some cases, I saw, because I was kind of part of not part of it, but I was close enough to see sort of like one of these doctors that sort of was corrupted and had one of these pill mills going on, and law enforcement eventually caught up to them. So I got to see where, like, avenues where loopholes like those would be closed up, which I thought were fantastic. And those also came with the introduction of electronic medical records, which luckily I've been in the industry since before and got to see pretty much the arrival of technology within medicine and now the arrival of AI. But essentially, I got to see where loopholes were, for, basically some foolery to go on to get closed. But at the same time, I see, doctors sort of have lost. A lot of doctors are losing. They're like, well, what am I really working for here? If I spend 2 hours with a patient or an hour and a half with a patient going over all these different things, and you're only going to give me but so much money, what's my incentive to really sit down with a patient and give them the time? I might as well just, churn them out. Either way, I'm going to get paid a certain amount. So it kind of, it impacted, I think, the quality of care that was being delivered a lot. It also did, however, leave the avenues for improvement. It left like the opportunities. That's where organizations like the work I work for and many others have sort of taken advantage to sort of leverage data and things like that. Things that doctors generally are not trained to do, like whether it be business savvy, like how do you optimize your billing so you can get, keep your revenue cycle, just well managed. To also what quality outcomes can improve even how you get reimbursed through health insurances. So it's a mixed bag. It's been a mixed bag, honestly.
So they yeah, I think you hit the nail on the head. It's a question of unintended consequences and distortion of incentives. It's one thing that I've wondered my entire career, is that why is an hour with an experienced doctor with like 30 years of experience, why is that not worth more than somebody who just started their career? What incentive is there to do a good job? It's just like it becomes a volume business, and that's
Yeah.
what everyone's unhappy with, essentially.
Yeah, and I talk to doc sometimes when I'm out and about with my kids. If we have a doctor's appointment, we're sitting down in front of a physician, and even I just start randomly, eventually asking questions just because I can't help myself. Like, how do you feel about the EHR you're sitting in front of, and how do you feel about all this technology and things like that? And oftentimes the answers that I'm getting are very gloomy and sort of defeated. A lot of doctors are out here feeling like not just the commercial side took over, but now technology is completely taking over. I think I mentioned to you on Twitter that I spoke to a doctor who said his prediction is that soon AI will be making almost all the decisions. It'll just be a person sitting in front of you just so you have a sense that a person is there, but the AI is giving them all the treatment plans and all that, and I don't, I don't think that's too much of a stretch. I think if a company can figure out how to optimize their revenue through that, they're going to do it.
Yeah, it's definitely worse on the coasts. I left clinical medicine over 6 years ago, and I shifted to the laboratory. But the algorithmic-based approach is something that they delve into in depth in Thinking Fast and Slow by Kahneman. And we often resist the reliance on an algorithm-based decision, even though the evidence says that it's better, it's more accurate. And we as human beings tend to think that our judgment is always going to be better than an algorithm, and sometimes it is, but a lot of times it isn't. So I don't know what's going to happen in terms of AI replacing primary care physicians. I think you ultimately get into this situation of accountability. So, like, who is responsible for a misdiagnosis, and who is responsible for emergency care where you don't have time to plug it into a computer? You just have to act. And so there's all these other answered questions, and it's like, I think we as a society are starting to realize the consequences of putting too much trust into the big tech companies, as if they are somehow benevolent, and it's not. That's not the way it works. They're for-profit enterprises, which is a good thing, but they're going to do what they need to do to
Right.
maximize.
That means that ultimately their main goal is that bottom line.
Yeah, and so these types of things are ultimately like, do physicians actually value their time? Their behaviors tell you that they don't, right? Because physicians are willing to let the government just ratchet down the reimbursement for their time. I never understood that, but that's.
I think there's a lot of like, what can we do? I think that's the general attitude I've seen. Is like, CMS decides and that's it. CMS decides, or the CDC decides and the CDC decides, And I think it comes a little bit to what you said in terms of accountability. Like, doctors just rather say, you know what, we're deferring to this higher authority. This is what they're saying. We don't want to stick our neck out.
Interesting. Well, they're going to write their own history. I mean, I created this podcast as, basically to advance the interests of physicians. But, it's like you can only do a small part, your part to kind of make the system better. And at the end of the day, physicians have a lot more control than they say, but it's just they have to get involved from an advocacy standpoint. And
I agree.
Most of them do not. I mean, it's like less than 10% of physicians that contribute to their specialty-specific lobby, whereas you're up against these killers. They're big insurance and hospital industry, pharma industry, device industry. I mean, these guys are like professionally organized lobbies.
Right.
So it's not that like physicians have the time and the manpower. They just choose not to get involved, and now they're kind of looking at the consequences of not being involved. Whereas I think that actually sales, marketing, writing, business, like these concepts like should be introduced like from day one. You know, as like a pre-med student, you should know exactly what you're getting yourself into, and you should learn from other professionals, right? Dude, I came across like some marketing, I don't know if it was a copyright, yeah, Tori Dolly, like some coach. I went to his website. This guy charges $1,000 an hour, like
Cool.
for consulting calls, just to like, if you want to help, you need help building your brand. This guy's gonna charge you $1,000 an hour. I mean, he's got like a college degree, and that's it. You know what I mean? So
That better,
yeah,
there
like
better be
there's
some guarantees behind that.
some guarantee. Well, it's like physicians should learn from that, because it's like if you're adding value,
Right.
if
Yeah,
you're
that's
adding
true.
value to someone's life, then they're going to pay you a lot of money to solve their problem, and
This is very true. Yeah.
and it also tightens up your game, right? So you have a reputation to protect, and so you will get that person's cholesterol down.
Like a mechanic who's a good mechanic, right?
Yeah,
Yeah. Word of mouth
absolutely.
is enough, and the work speaks for itself, right?
Yeah, absolutely. So you started your career on the East Coast. You went to this kind of apprenticeship program. You started out in phlebotomy. You mentioned that there was like a hiatus somewhere in there. Can you tell me a little bit
Mhm.
about that? What was going on?
Well, when I moved out of New York City, I was still sort of doing the whole, living in another state but commuting into the city for work thing.
Okay.
And after a while, it just got kind of heavy. And I needed to, I was like, I want to continue in healthcare, but I wasn't having trouble landing a job where I was. So I switched to the other industry that I've worked at most of my life, which is fitness. And I started working for a big brand, one of these big gym brands, doing sort of like fitness sales, basically selling personal training and managing trainers and stuff like that. And did that for a little while, which was nice and lucrative, but too much time. It requires so much time out of you. And I was like, listen, the money's nice, the commissions are nice when they're coming. When they're not, obviously it's not so good. But then on top of that is like the amount of time that I would have to spend away from the kids and stuff. I was like, it's not worth it if I'm making all this money, but I can't be around them. So I moved into property management, and I did that for about roughly 3 years, something like that.
Okay. And that
It was an interesting experience. I brought obviously some stuff with me coming from healthcare that helped out, sort of like
Okay.
the eye for sort of being very like hypercritical and looking at the information and seeing what does this mean. Like, obviously a very, like, not to get too into it, but if you got a building and you have X amount of, say, occupancy, and you need to be at a certain amount for the building to be profitable, like what is the trend, what is it, like, is it cleanliness, is it the service, like whatever it is, and then finding ways to mitigate that. So it was an interesting time. And luckily, what was really weird about it, and all my friends in the healthcare industry were like, you left right at the proper time, because I left right like maybe 5 months before COVID hit. And I didn't return to
Nice.
healthcare until like well after COVID ended.
Nice.
So I kind of missed working in healthcare during that time, although I had the inside scoop through all my friends. But I got to see it from I got to see healthcare, the impact of COVID from a different perspective. But with that sort of healthcare professional thing in mind throughout the whole time, which was very interesting to see.
So, like, what was your perspective from the outside of the industry?
So, well, if we want to talk about like, the
'Cause you-
virus and the vaccines and all that itself,
Which
I'm
you
sorry,
were
you were
doing
saying?
property management, so that must have affected your day to day, right?
Oh, yeah, in different ways, right? Because suddenly the people say you got somebody who isn't paying rent, right? And then you have to come and do like a check of their apartment or whatever. They're definitely not letting you in now. They're hiding behind the mask
Okay.
and the 6 feet and all that.
Okay.
I got to see things like, I'll tell you one story that actually affected me, because it was sort of like the early reminder, or the early, it was only about maybe 6-7 months into me working in property management. And they sort of gave me my first real set of buildings to manage on my own. It was like these newly acquired buildings by this company. And I get a call like day 2 of being property managed for this one property, that somebody an elderly man fell out in front of the property. Like one of my maintenance people calls me. So I go rushing over, because I'm like, oh boy, here we go. Like, what happened? Was there a slip and fall? Like, what's going on here? get there and find out it's a medical situation. The guy collapsed. I wasn't sure if, if it was a heart attack, stroke, whatever it is. I start trying to, I'm kind of like checking his vitals, and I'm like, did you guys call 911? This guy's not responsive. And they're like, yeah, the town that it happened in, it's notorious for having horrible 911 response times. So this man was in his like 80s, and I'm trying to, feel for a pulse, and I'm like trying to talk to him, trying to do the little bit I know how to do. I'm like, did he seize up? Was he foaming? Was he moving at all? Because they saw him fall over. And they were like, no, he was at his door and he just fell over. And so I'm like, I get on the phone, I get on, I'm trying to get, them to respond faster. And ultimately they show up. They kind of like pretty much, they were all but pronounced him on the scene. They hit him with the adrenaline shot, didn't come up. Nothing, basically at one point they maybe 20 minutes they had him in the ambulance. They're sitting there, they're doing chest compressions, they're doing everything. They get like a faint pulse and they decide to rush him off to the hospital. So now I spent some time trying to get a hold of like any family members, anybody we had on file to, let them know like, hey, listen, this happened. Couldn't get a hold of anybody. But I did eventually figure out what hospital he was in, and called to find out the next morning that he was brain dead. He had a stroke. And it messed with me, and I'll tell you why. So this is like, because of what I've been doing, I've worked, in healthcare. Mostly what I've worked is working in underserved communities, meaning I'm looking at, basically Black, Hispanic folks, poor people, basically. Doesn't matter what demographic, it's depending on what neighborhood you're looking at, but just folks that are not, are not well-to-do and maybe have issues, taking care of their health because of that. Okay. And this man fit the bill. He was like an 80-something-year-old Black man living by himself. Coming back from the store, it was like middle of August, I think. So it's like 90 something degrees. For whatever reason, he's in a full like church suit, old school, I guess, right? Like, whatever, you're going to the store to get your, bag of chips, you're still going to be in your suit. But that's the stuff that stood out to me. It was like I'm looking at his age. I'm looking at the fact that he's a Black man. I look at where he's come. They were like, he looked like he was just coming back from the grocery store. So I take a peek in his grocery bag, and it's a giant orange soda, 2 bags of hot Cheetos, and a couple noodle soup. And I'm like, here it is. This man's probably has, man's probably having a stroke. Like, I said this to myself, like, while he's on the pavement. Like, and, come to find out it's exactly what it was. And then, his family eventually got a hold of me, and it was one of those things where I had to let them in the apartment or whatever. After the fact, the man ended up passing away like a day later. But it was sort of like that early thing, like, man, this is not where you belong. You really, maybe that industry does need you again, and it's like for a few years, I kind of stayed out of it. And then eventually it called me back.
Wow. So you got back into it, but you are originally from the Dominican Republic, right?
Yeah. I was born in Dominican Republic. We came here, I was like 8 years old. And pretty much I grew up in New York City after that.
Okay. So,
yeah.
I mean, was your family in the Dominican Republic at all involved in the healthcare industry? Like, was that an influence on you?
So it should have been. Funny story. That's a good question, actually. I didn't grow up super, so, I kind of come from like a broken home situation, right? Like my parents were divorced when I was like really, really small. But my father was always kind of tried to be around as much as possible until I was like 15. In fact, I didn't even know about the divorce till I thought they were just like a really unhappy couple, because he lived with us till I was about 14 or so. And that's when he finally, like, it was like, all right, it's getting too rough and you guys are getting old enough. And he, he took off and, went off to live on his own. And for years, I would maybe see him every few months or whatever. So I wasn't super close to my dad because of that. And I, my mom being a single mom and trying to do everything for everybody.
Okay.
Didn't spend a lot of time with her. So I didn't have like a typical nice, family setting or growing up. But as I mentioned earlier, I had like a phobia because my mom sort of had heart disease since she was in her 30s.
Oh, wow.
And actually just had a heart transplant about 3 years ago, I think it was.
No kidding.
She had been on the list forever, but she was kind of fighting it, didn't want to do it. And finally we convinced her to do it. She was on an LVAD first. She was born apparently with just like some kind of I remember it was cardiomyopathy. That's what I remember the original diagnosis was. So she, her heart just kept enlarging and getting weaker. over
Wow.
time. So anyway, my brother, unfortunately, at like 21, it hits him. And by like 22, I think it was, he has a heart transplant.
Wow.
And so like growing up, like just being in and out of hospitals for her, oh, you're getting that call when you're out somewhere and it's like, hey, mom's getting rushed to the hospital again. And it's like, run, just like, I was like, I would never want to be in hospitals. Like the idea, even like the beeps of like all the, the EKG and the pulse ox and all, it just like, I would, wow, like my hands would get shaky, even just walking into a hospital. Cause I was like, I was prepared to just receive bad news at all times.
It's
Um,
traumatizing.
yeah, it was a bit traumatizing for me. And then over the last few years, starting a family and having kids, you kind of start looking back into your history and your family and stuff because you want to be able to tell your kids like where you come from and all that stuff,
Yep.
And even though I wasn't close to my father, I've always had some level of connection. He's around; he can call me whenever I'll go visit him if he wants. And we get to talking about. I wanted to talk to them a little bit because my father's is mixed. He's got some Chinese, a big Chinese population in the Dominican Republic. So my father's part Chinese.
Oh, okay.
And I was just asking him stuff about that, and through that he tells me, your father and your grandfather and your great grandfather were both very good doctors, very well known doctors in their time.
Interesting.
And apparently I found out that I'm not sure if it's a clinic or a wing of a hospital in the hometown, the town that my parents are from, that is named after him. Said I've only found this out in like in the last 2 or 3 years. So I was like, this explains why, like, for example, throughout high school, I could like sleep through. I remember specifically, I would always fall asleep in my second period biology class.
Okay.
And we had PTA meeting. My mom comes. He's like, listen, I have only one complaint about your son. And she was like, what? He was like, he can't stay awake. And she was like, so he's failing. He's like, no, don't get me wrong. He's like the second best student in my whole class. But for whatever reason, he can't. And I just could. It would just enter my mind through osmosis. All the biology would just enter my mind. It would just stay.
Interesting.
And then I guess that might be, something inside me. Maybe it might hard coded in my DNA when I stuck that needle in that patient for the first time. That was that trigger. We're like, oh, this is where I belong. Somehow I belong in this field.
I got you. So, like, what is?
It's funny
what did
enough.
you-
I'm sorry. That's why I mentioned it earlier that was the switch right there.
Okay.
I mentioned, that basically I had that phobia. I just wanted to bring that up real quick because there was a moment in that where I don't know what it was that when I spent a couple years thinking about like, would I be a doctor, would I be a nurse, would I be a nurse practitioner, would I be a PA, what would I do? I played with the idea of just going long term and maybe trying to do surgery because that kind of was sounded interesting to me. But then through talking to doctors and seeing some of the challenges, starting to work in like quality improvement and all that, I sort of had this idea that I could, like you said, try to take this on and do whatever I can as one doctor or one nurse and do my best to try to do the, for the system and for the people around me. Or I could work in this capacity in public health where my work will touch millions of lives or thousands of lives at a time. And that's ultimately what drove me to that. That's something that I meant to ask earlier. That's all.
Yeah. So are you are you like a MPH professional, or like what was your
I'll give you another
eventual line of
interesting
training?
story.
Yeah.
Here, interesting story. I have not even an associate's degree.
Oh, wow.
So I like to call myself like the poster boy for there isn't just only one way to make it.
Right.
What I did was supposed to be good enough for me to have, a $20 an hour job. That accreditation that I got. And I've worked in one of the premier public health agencies in all of the country. Lucky enough to have done so.
Good for you.
And thank you. And the thing about that is that I've done the work that I've done. It's not just that I've worked for this company. Like, you and I talk about this all the time, like the prestige seeking that goes on.
Right.
I use that to like kind of just, I use it almost as a beacon for people. Like, look, if I can get there, with this, with what little I have, what can you do?
Absolutely,
Like
man.
I especially point to my kids when I say, like, what could you do if I'm showing you here that you can be this without having to do that, or that with hard work you can do whatever you want to do. Like, that's kind of like the only reason I even use that. But in general, it's been the work that I've done. I get to see the outcome. I see it in data. I get to see how the work we've done has improved, diabetes and hypertension outcomes throughout the 5 boroughs, for example.
Okay.
And in other cases, I've gotten to see it. I worked on this one program. We used to host this organization called Resolve to Save Lives, which is run by somebody who was the former health commissioner for New York City years and years ago.
Okay.
And I got to work on this program where once a year they would come to New York, people from China and India and other places in Europe that were trying to figure out how to set up healthcare infrastructure in rural areas in their respective countries. And I'm sitting in this room advising people who are, basically diplomats and ambassadors from their nations, and they're asking me and my colleagues, how would we address this for example, we were trying to address this one issue in rural India where doctors are seeing hundreds of patients a day, but the interactions are lasting 30 seconds at a time.
Wow.
And it's how do we control something like hypertension in in a system like that? I'm like, you can.
Yep.
You gotta find a way to build the system, and you could take these lessons that we have from all these years of trying this in a big city and see how you can apply them. But I mean, it requires so much. How are you going to get the technology out there to even organize all this? So it was interesting. But the fact that I've gotten to do all of that without killing myself, without indebting myself, without getting a meaningless degree. And I don't say that all degrees are meaningless, but I think a lot of people.
Most of them are.
Yeah. I think a lot of people put too much stock into I'm like, listen, unfortunately, that piece of paper is the price to play, but don't put all your stock in it.
So can we break down what you do a little bit more? You got to dumb
Of
this
course.
down for me, because somebody might be able to follow in your footsteps, because college is mostly a waste of time and it's very expensive. So can you just break down, explain to me a complete, I'm a 5-year-old, what exactly do you do, with your data at work? What skill set are you using and what problems do you solve?
All right. So here's a good one. I'll give you an example of one of the things I'm currently working on. There is a university, a very well-known university, famous university, that is doing a study right now in conjunction with the agency I work for. In order for them to see how, to basically get the answers they want, they need to see a couple points of data. Number one, they need to see how often our team and our people are interacting with them. What type of interventions are we training providers and their staff on? What type of tools or resources are we providing for them to provide to patients? And then we sort of track okay, these patients that are using these resources, are we seeing any improvement in their blood pressure readings? Are we seeing an improvement in their A1C levels? Are we seeing more engagement in patients taking their medication or even going to the pharmacy to fill? Because we have all these data points, right? I can tell, and I can look at this on a very, sort of directly patient level data, or I can look at this as aggregate level, where I can look at, say, okay, this patient definitely had, say, this intervention done, this sort of counseling done by this provider. I see that it's documented here. And within 3 months, this patient sort of became more compliant with taking their medication. So medication adherence is a big thing that we would look at right now.
Okay.
So my job is to not just collect patient level data and aggregate data, and sort of, we have to organize it a certain way, and then share it with some of these partners, these universities and things that work with us, so that they can do their own analysis. Sometimes I'm doing analysis on this data, so to sort of provide reports of what it is that we're seeing. It's a mixed bag, man. It's honestly a lot. And I'm also helping develop reports, different reports that can be rolled out, particularly for this one EMR company that allows us to see just tons and tons of data out of this one report and use it and utilize it in different ways.
Okay.
So it's a lot of different things that I work on.
That's awesome. I think you can definitely impact a lot of lives by analyzing the data that is collected from day-to-day clinical practice. That I think a lot of young kids probably don't realize this, that you can have a tremendous impact on people's lives, not necessarily by being a practitioner, but by being involved with organizing and analyzing the data from the practitioners and helping the system make better decisions on how to reduce disease.
You know what's interesting is that since my time in it, I've seen like a giant spike in MPHs and MPAs actually.
Okay.
And in in New York City, what I was seeing is a lot of people from like Midwest, West Coast that were getting their MPHs and they coming to New York to work. Just because, like I said, the New York City Department of Health at the time was, sort of like it still kind of is sort of on the bleeding edge of a lot of stuff.
It is.
So a lot of people, wanted to come and get, experience there. But then it became, like you said, it just became prestige seeking. They were like, all right, now I have NYC DOHMH on my resume. Kaiser Permanente may want me as a director or something. Like that's what
Yeah.
it became.
Yeah, it's
So-
really it's
Yeah.
it's kind of, it's not my cup of tea, and I think that paradigm is kind of collapsing. It's like it's just eroding, and one of the missions of this podcast is to get stories like yours out there, that the era of status and prestige chasing, it doesn't have a lot of benefit anymore because you can earn a lot of money building your brand on the internet while you're
Right.
in training. In fact, that's probably a better use of your time. So, like, take for example, as you're familiar with, like people in academic medicine, they only promote when they publish papers. But these publishing houses are smart, right? They knew, like, back, like 30 years ago, that scientists and doctors are very motivated by prestige. That's how they promote.
Mm-hmm.
And they were essentially willing to work for free. And so they were making money by publishing these doctors and charging them fees to publish, and not get, and the doctors weren't taking any fees for their publications. It was a total highway robbery and a very lucrative business for them. And now the cat's kind of out of the bag, and this is like how clueless a lot of these young doctors were, right?
It's literally like, hey, you have the product, but you need to
Right.
pay me to sell your product, or you need to
Exactly.
pay me for me to have your product. Like, that
Exactly.
doesn't
It's
make any
the
sense.
dumbest shit I've ever heard. And, we all have to pass through academia to get credentialed, to like do our training, right? It's all
Right,
like a big, NYU hospital or wherever else, Mass General, you know what I mean? Like everyone's trying to get into a big name hospital to get their training because you see a lot of complicated diseases and you see high volume, and you just get to work with some of the smartest people, in the country, which is naturally a good thing. But times are different now to where there's not a lot of benefit to just racking up prestige points, because I can tell you right now, like even at an elite institution, like an associate professor in medicine, you're making less than half of what someone's making in private practice, and private practice too. Like these corporate health systems, they want to chase it away, right? They're intentionally lobbying to lower reimbursement so much to where you can't practice. And it's only in states like Texas, the Southwest, the high desert, Florida, some Midwestern states where it is still physician friendly and private practice is still like, you still earn a good living, and it absolutely should be that way. But, like there's academic jobs that pay like, dude, it's like you get like a trained doctor, he's like hardly making more than a PA. I mean, it's just kind of ridiculous.
One of the doctors that spoke to me, that sort of, there's many factors to why I ended up not choosing to try to go back to college and go to med school and all that, is because some doctors were like, listen, it's not worth it. You spent so much time being sued and blamed and this and that. I guess that, like, in hindsight, a lot of them were trying to just like sort of be cautionary about my romanticism with the whole thing.
Yeah.
But I took a lot of their stuff to heart too, because I'm like, man, it's true. Like I'm watching how some of these the amount of hours some of these guys are putting in. Some of them are coming to this clinic after working a 12-hour shift. One of them, I remember this one doctor from, I want to say he was African. I can't remember if he was Nigerian or if he was from Senegal, but Dr. Darku. I remember this man came out of Harlem General Hospital, came out of an 8-hour surgery, and then came over to our clinic to spend 7 hours seeing patients back to back, no break.
Wow.
I'm like, how? I'm like, come on, man. People can't talk to me about physician burnout isn't real. It is real, and I do know that some people are using it as an excuse for a lot of shit nowadays. But, there's nobody, I've never met anybody who works harder than a doctor that truly loves medicine.
Yeah, it's like people like that, that pull an 8-hour surgery and then pull another 8 hours of clinic. People like that should be fucking millionaires, right? Medicine absolutely
100%.
should be lucrative because then you're going to continue to attract the best and the brightest, right? But the opposite is happening now, right? They're actually making med school pass fail. And they're lowering the admission standards, and
that's horrible.
They're doing this on purpose. This is totally woke corporation driven, because they're trying to silo healthcare into the large health systems and employ all the doctors so that they can't really be rebellious. They can't own their own practices and speak their minds. That's what they're trying to do. But I'm an optimist, and I don't think they're going to succeed at it, because as you're seeing now, more and more physicians are just choosing to just say fuck you to corporate practices, and they're just starting their own concierge practices. Now,
so isn't there a double-edged sword with that too, though? Where there's a lot of folks that are kind of getting left by the wayside because they can't afford these concierge packages?
It totally is. It totally is. But physicians aren't to blame, right?
No, they're not.
This is very much a systemic issue that will easily be solved by everyday citizens putting pressure on their representatives. The citizens have to complain about this. They have to say, look, these insurance companies are charging us $600 a month for our family fees, in some cases more, and they're just not paying. When grandma needs an MRI for her broken, knee or a dislocated shoulder, the insurance just won't pay. Or for these ER visits, they just won't pay. Or you go to these predatory hospitals where, they'll price gouge you for, dude, I know a guy, his wife got hit by a car, broke her hip, went to the ER. They try to charge her $65,000 for the ER and the initial ortho workup. And it's the intent is to make people into debt slaves. Right, so they're intimidated by the system, and then they're stuck, on these payment plans for the rest of their life, right? So not enough people are kind of talking about that side of the game. They kind of look at it like this negative sum thing. It was just oh, it's a finite amount of resources. We can only spend a finite amount. It's no, no, that's not how it works. At the end of the day, medicine is a service, right? So there's a baseline level of healthcare that absolutely has to be free, right? There has to be a free option so that everyone is covered, right? Like prenatal care, pediatric care, for the elderly. There has to be some baseline, safety net healthcare coverage. But for everyone else, people are willing to pay a premium to get their problem solved. So if I'm gonna pay to see a doctor, I want them to spend time with me. I want them to explain my disease, how my disease works, how do I cure it, how do I lose the weight, how do I get rid of the high blood pressure, the diabetes, all this stuff. And if you really want it, motivated people are willing to pay to have their diseases resolved.
Yes, of course.
So I think you definitely have to have two options, and it's when people start to see what's actually happening in healthcare, where they're trying to corporatize the whole system and then dumb down the practice by recruiting an army of mid-level providers and an army of AI bots to do the work. And this raises all kinds of ethical problems in terms of who's responsible for bad decisions that are made. A lot of people don't realize that the practicing physician is totally under a microscope. You have to re-credential every year. You have to prove that you're,
Yeah.
that
Mm-hmm.
you're keeping up on things. You have to document
Mm-hmm.
all that. You know what I mean? It's not like,
You have to keep up with every guideline the CDC and everybody else puts out every year.
yeah. So it's
Crazy.
there's a lot of work that goes into it. I still think it's worth it because I enjoy what I do. But then again, being a pathologist, I'm behind the scenes, so there's a lot of negative stuff that I don't have to deal with.
Yeah, I'm sure, because I guess your job is more task oriented. It's like get this, this test done as I guess as accurately as possible, and get this report out as quickly as possible, so a decision can be made
Right.
for this person, right?
Exactly.
Yes.
So I don't have to get involved in kind of like the social work stuff that happens, kind of on the front lines. So
Right.
so I kind of have the luxury to to talk like this, but I started my career in primary care, so like I have a lot of empathy for people on the front lines there. So what would you like to see change, like within your I guess locus of power?
I'm very interested in this whole how technology can, because obviously, clearly, no one's gonna say technology is the downfall of medicine. Like, everybody understands technology could only help. It's how we're applying it. When you talk about the AI thing, for example, I see some, because I've worked with many different electronic medical record companies, but there's one that's pretty major, particularly in the East Coast, and I deal with them a lot.
Okay.
They're a company based out of India,
Okay.
and they've built some pretty cool stuff in their platform. They just rolled out in the last few months a sort of AI bundle, which I think is awesome because it sort of automates some of the processes that my team would do, right? You can talk to this AI and just say, hey, show me all my patients who came in last month who are hypertensive and diabetic with a blood pressure reading above this, and that don't have a follow-up appointment, right? And it would spit out, it just generates it like that. It's the AI. It works super fast. It would just look at, go through the
Nice.
database, find all those patients. And I'm like, that is amazing, because now you don't have to rely on somebody like us that's trained in all this stuff to come and train your staff on a rotate, which, by the way, it's a whole other thing, right? Like that's been a big challenge, right? It's like we train doctors to do certain stuff, but in a lot of practices, the staff is a revolving door. So then, like, the doctors didn't really know the stuff that we taught the staff. So now we got to go back in and retrain new staff every so often.
Oh, I see.
I see. So, like, technology brings that challenge with it, where it's like, well, you got to be able to handle the technology too. But something like AI sort of makes it so that, look, you barely need to know how to handle it. You just need to be able to talk to it, and then you got to know what to do with the information it gives you back, right? So something like that is wonderful. What I don't like, things that I don't like, are more tied to sort of, I think you brought this up earlier, like ideology and certain things that have crept into healthcare and public health a little too far, right? Like,
Yeah.
We're all for everyone having free speech. We're all for everyone having, their right to exist and dignity and all
Right.
of that. But there's certain things that, in my opinion, have gone too far, and I see it playing out. Like, I hate when I'm in a meeting with a group of people whose work will 100% in fact just impact policy, and they're talking about, we need to get rid of the patriarchy in healthcare, and I'm like, what are you talking about? Like, it has nothing to do with it. Like, I've never ever like, you have your people who have their preferences, but I've never heard anybody say female doctors are useless. So stop it. Just please, let's stop it with all this patriarchy. Let's stop it with all that stuff. Let's get back to the real issue. If you want to talk about, something and you have some real clear evidence about it being a problem, sure, let's put it on the table. Let's discuss it. Let's formulate a plan on how to attack that. But when you're just talking to me about stuff that doesn't hold up by the very science that we deal with in every day, you understand what I'm saying? Like, here's an example. The CDC put out sort of a mandate, because of this whole, everybody has a new gender identity every week. Everybody has.
Yeah.
Now how people identify, even with race and ethnicity, even. It used to be a simple thing. You went to a doctor's office, you got a sheet, when you were being registered, and it was like, are you black? Are you white? Are you Asian? Are you Hispanic? Are you, there was maybe a few, like Pacific Islander, indigenous maybe. Now there's thousands of options in both race and ethnicity. And by the way, some of them overlap. You can now go on to say my race is Dominican and my ethnicity is Dominican. That doesn't make any damn sense.
It's
You know what I'm
crazy,
saying?
man.
Like,
They're taking,
yeah,
it's
it's
just, they're getting distracted. They're getting, it's getting too,
yes,
they're focusing
it's
on
gotten
stuff.
crazy.
It takes away from the mission.
Yes, exactly.
It's like
Exactly. Because
feeding-
here's one, I don't know, like this is one that I always
Yeah.
kind of harp on a little bit. I'm not anti-gay, I'm not anti-whatever.
Right.
But here's my problem. In order for someone to receive gender-affirming care, they have to what? Be diagnosed with gender dysphoria. Is gender dysphoria not a mental disorder in the DSM? Yes, it is. Show me another disease where we affirm, or show me another mental disorder where we affirm the insanity.
Yeah.
No one can ever point to it. I'm like, why are we doing it with this? Why? I'm like, this is not the path. I'm like, listen, I am all for us finding a way, an empathetic way to deal with this situation. I get it. It's happening. It's real. Some people are born confused. Some people become confused. Some people, all the different, whatever the spectrum of things that come with that. But we got to be realistic.
Yeah, it's,
We can never,
yeah,
there's got to be one side that's like anchored that says, no, but this is
Right,
the reality.
Yeah.
I get what you're saying, but this is the reality. You
No,
know?
I totally agree, man. Like it's gotten way out of hand, and it distracts us from the overall mission of just like providing general healthcare, bro. Like we still haven't cured hypertension, okay?
Right.
Let's
Right.
focus where the money's at: hypertension, diabetes, coronary artery disease, obesity. Let's just focus on like the bread and butter first. Let's get that handled. We're working about all this other stuff. But you're talking about people that have like less than 0.005% of the population that legitimately has this issue where they don't know what gender they are, or they're confused about that. And then the rest of them are they don't actually have gender dysphoria. They're just homosexuals, and that's fine. Like I've never
that's
had a
cool.
problem. That's cool, man. Like they bring the value of the properties up. Like I've never once like been anti-gay or anything like that. But it's like y'all are making this a fashion, because
Yes,
that's what
exactly,
the media that's what the media companies are trying to do, because there's a multitude of other agendas at play. And
It created new opportunities, I think, for people, for grifters to make money.
yes,
I think that's what all it is. I think that this is part of what we talk about, commercialization of healthcare. I think they realized, they were like, oh, we can create a whole new set of billable codes. Oh, we can, sure, of course, we should definitely care about this population now. But meanwhile, if there was no way that a pharma company or a surgeon could bill for that service, it would be like, this is not the way we don't treat this.
Yeah.
Like they just wouldn't even be considered a disease. But so my point is to say, like, I prefer for us to just get back to the science of it all.
Yeah.
And not the political aspect of it.
Yeah, absolutely. And I think what we are encountering at light speed these days because of the internet is the inherent paradoxes in just human existence. We do so many things that just don't make sense. I do things that don't make sense, like every day, like I contradict myself. Like, so it's just the human condition is that we just often do things that conflict and paradoxical. So we're not
Very true.
We try to be as consistent as we can, but with that specific issue, I think we're getting off the main course a bit. So, but you're an interesting guy because you've got some other things that you're into, such as martial arts. So how has martial arts helped you along this journey?
Man, so I didn't grow up, in traditional sports. I kind of wanted to try baseball as a kid, being Dominican, but first time trying it, didn't like it. Kind of enjoyed soccer, but never. Parents tried to put me in tennis camp. I got myself kicked out on purpose. Like, couldn't play basketball, kind of
Nice.
could play football. But I discovered martial arts maybe around like 5 years old, just from like watching Kung Fu. I don't know if you remember Kung Fu, the television series.
Yeah.
Yeah, like we used to watch that in Dominican Republic, and my brother was like obsessed. Like I remember my brother once tried to carry the rice pot off the stove the same way that I don't know if you remember, like it was like that ceremony with the big pot that was on the fire and it had the tiger and the dragon on one side. And it's like it was like the the rite of passage, like they had to like brand their forearms and then carry the pot across the room or whatever.
Okay.
Like my brother would try to carry the rice pot, like just trying to mimic that scene.
Awesome.
And then Bruce Lee, we discovered Bruce Lee and we got big. And then also we that was around the time that like our family told us, like, oh, you know, there's Chinese in your family. So we just got like super into all things martial arts after that.
That's awesome.
And then I grew up with it. It's sort of been my, my religion. It's been my code of ethics. My whole persona is based around it. I don't, I think I'm kind of like a person born out of time a little bit.
Okay.
I'm a little bit old school mentality.
Yeah.
And it because there's a lot of traditionalism in martial arts, it fits my personality. It's taught me to power through. It's taught me to not give up. It's taught me to believe in myself, even when all the odds, like I said, I don't even have an associate's degree, and I'm working around MPHs and PhDs. You know what I mean?
That's awesome.
So it's given me a tenacity that a lot of people don't have. In fact, I've always often said it, like if I could be a dictator, if I could be, president, run the world, whatever, I'd be like, man, martial arts is now a mandatory thing.
Yeah.
Not everybody has to be Bruce Lee or Jackie Chan, but I think that there's unique things that martial arts brings, unique challenges, unique ways it challenges the body and the mind that other sports don't necessarily capture.
I agree, man. I think at least like a year, just like a basic white belt, like pick your sport. I did jiu-jitsu in college and a little bit as a pre-med student, judo and jiu-jitsu. And when my son gets a little bit older, I'm definitely going to hit the mats again and kind of introduce him to it. I think just like baseline, I totally agree with you. That's probably why we tend to get along, at least in written form on X. Is that I'm a bit old school too, and I like that traditionalist aspect of martial arts, the code of honor. I think it teaches you to be respectful, and there's nothing quite like getting the crap kicked out of you by some person who's 100 pounds heavier than you, who could literally snap you in half, and you have to check your ego and tap out.
So here's the thing. Here's the thing here's why I'd say it has this one factor that other sports don't have.
Yeah.
You can learn to overcome a bigger person, say playing football. You can learn how to take defeat through any sport, really. You can learn how to get back up, all of those things. Here's the one thing that happens though, and unless you're playing something like tennis, most of the time you're playing a team sport, meaning you can kind of deflect some blame, right? I did my best, but team just wasn't together today. Or the other team was just better today.
Yeah.
But in a fight, it doesn't matter. It's all you.
Yeah.
It's the ultimate test. It doesn't matter what your coach said. It doesn't matter what your coach told you not to do. It doesn't matter what your training camp, none of that matters anymore. The only thing that matters is how did you react when the action came to you, and what action did you take? It's all on you. So it creates, and I've never seen, and I'll say, this is why I think the toughest of all, the mentally toughest of all is wrestling. There's no one who comes out of a wrestling room weak. They're all savages, mental savages, right? And the reason for that is because they get their ass kicked. They go through a meat grinder every time they're in practice. But guess what? While they're going through that meat grinder, they also got to beat some people up too. So you get to see like how life really works through all of that. Sometimes you're going to be the nail. Sometimes you're going to be the hammer. Sometimes you don't get to choose which one you are, but you better be good at being both.
I love it. So many metaphors to succeed in life. I love it, man.
Yeah.
I love how you get hyped up when you're talking about that.
I do. I love martial arts.
It's fucking awesome.
Yeah, and like just the human potential. Like that's something that's always been like a big interest of mine. Like human potential and what we could do with the mind and the body.
And confidence
has always been a big interest of mine. Yeah. And so, I just think that this is like the most powerful avenue we have to experience it. That's all.
Dude, like confidence is so important for young people, and the
Mm-hmm.
older I get, and maybe you've observed this too, maybe you have a different point of view, but I have observed, at least in myself, that everything in life is essentially a confidence issue. Um, there's certain things that like I'm never gonna be like elite NBA basketball player, but
No.
within the skill set that I've already built, the only limiting factor is confidence, like self-belief.
Correct.
And I
Yep.
think like that, martial arts, like just basically persisting and enduring something intimidating, and then just dealing with it. Like some days
Here's a good one.
you're gonna be the nail.
Exactly.
Yeah.
Yeah, and exactly that's my point. Is that some days you know that you're going to go into a losing battle, but you go into it regardless because it was the right thing to do.
Yep.
That's kind of the thing that I think it's taught me, and I try to impart that in my kids. And I'm like, listen, like my daughter's going through some things right now, but I'm trying to teach her, like, listen, telling the truth seems scary, seems like what'll get you in trouble, but it's the only right thing to do. And I'm trying to show her how, like, you know, you can make a choice to do the other way and not tell the truth or whatever. But I'm a big firm believer in that truth is just like water. It always finds a way where it's got to go.
Yeah.
You can contain it for a little while,
Yeah.
but eventually it's gonna erode whatever you contain it in, or that it's gonna evaporate. It's gonna do something. It's never
Yep.
gonna sit still.
Yep.
So it's eventually gonna come to where it needs to go. So, and if when it gets there, it can cost you something, you might as well just go with the truth now and eat the cost up front, because the cost is always gonna be bigger later on.
100%. Absolutely. So, man, before we wrap up, like I just wanted to say, I was curious, what is your next move, or are you kind of happy where you're at right now? Or do you see yourself pivoting at all?
Honestly, in the last few weeks, looking at how you put your content out, has sort of re-inspired me to maybe pursue content creation again. I think I will probably remain in healthcare.
Nice.
I'm not sure where I'm gonna go from here. I know my boss and we have plans, right? We have plans for the next 2 or 3 years, like for the immediate future.
Okay.
But where I'll go beyond that, I've kind of just been playing it by ear. But I do think that maybe I'll start exploring sort of my creative side a little more again. I used to do podcasting. I used to have a podcast that was all about health and fitness.
Oh, cool.
But I have a little bit of a mental thing where, like, I want things to be perfect. I do have a little bit of a perfectionist streak in me. So it makes it, for me to go into these endeavors, it can become like where the quality of my content suffers because I'm trying too hard to make it perfect. And I've noticed that consistently every time that I've tried, eventually I fall victim to that.
Yeah.
So it's actually been kind of refreshing just having this conversation with you, because it's like, man, if I could just be this loose when I'm hosting one, if I could just be this relaxed, and yeah.
Well, you are a friend of the 3 Deeper Cuts podcast, and I'd love to have you on again. Look, we have a lot of similar philosophies, man, and we're both, doing the father thing and just trying to do right by our kids and just make sense of what's going on. There's all kinds of wild things going on in the culture, and I think both of us are just trying to be a rock for our families the best that we can, and navigate this weird time. So
Yeah.
man, it was great having you on this podcast. And
No, thank you, man. I'd definitely be happy to come back on whenever you want, man. It's like you said, we could probably talk for hours about a multitude of things. So
fantastic.
this was awesome. This was a fantastic experience for me. I'm very happy you had me on them.
Excellent. All right, man. We will talk to you. I'm going to pause it now.
Yeah.
All right, Fred, one last question. Why are you a fan of Virgil Ortiz, and why should I be?
All right. So Virgil Ortiz Jr., a boxer. I don't want to say. I think he's at 135, 145. I forget where he's at. But I mean, you want to talk about what I think is the most terrifying kind of person to ever fight. it's a guy like Virgil Ortiz Jr. He's not bought into, like a lot of boxers nowadays, they all want to fight with like this hands low, Philly shell, kind of flashy style. I know that ever since the Mayweather era came around, everybody wants to sort of be this flashy, posing boxer that has all the perfect pictures and stills and all that, right? But this kid walks you down with a high guard, can stop you with a jab, can stop you with a right, can eat shots all night long. I mean, literally, it's like a little Mexican juggernaut that just walks you down until there are some fighters that they're fighting to win on points. Some fighters are fighting for glory. Some fighters just want to end you from the opening bell. And that is Virgil Ortiz Jr. Albeit he's very intelligent about he fights. Like I said, he just walks you down from a high guard. I mean, you want to talk about, what I think is like the perfect analogy for how you have to take on life, especially the harder your life is just shell up, but don't ever stop moving forward. Don't ever stop moving forward. And that's a kid that's also gone through some like mental health struggles. Like when you follow some of these fighters and you see what, the things they've gone through. But you were talking about a kid, I forget what his full record is. As a matter of fact, let me see if I can Google it real fast.
Yeah.
Virgil Ortiz Jr. About that. So yeah, no, I'm sorry. So if I could say that there's a person who embodies how you have to be, it's that. It's like you just walk forward. Challenges sometimes come from outside, sometimes they come from internal. It could be your own mind. It could be you gave up on that podcast. It could be you're too scared to put your content out. It could be, this fighter across from me is bigger. But that kid never, ever, ever, ever wilts under pressure. He just puts his hands up, walks forward. If you catch him, you catch him. You probably won't. But when he catches you, he's gonna make you pay. So I try to use fighters like that as sort of an analogy when I try to tell people like that's how you have to walk through life. It doesn't matter what the record in front of you is. It doesn't matter what the odds are. Just walk forward. Walk forward. Try to be as, I guess, in boxing we would call it defensively sound. I guess in life we would say, be just as mentally sound. Try to make the right choices. But whatever those choices are, whatever, good or bad, whatever the outcomes are, just march forward. If it's the challenge is external, march forward. If the challenge is internal, march forward. Because the only way you're going to get to glory is marching forward and trying to punch back. So,
love it. All right, Fred. Fantastic. That's all for today's episode of 3 Deeper Cuts, the lifestyle podcast for the practicing surgical pathologist, bringing you high-signal content fueled by 10% buffered neutral formalin. Hope you enjoyed listening. If you like this content, subscribe to the newsletter at 3deepercuts.substack.com to download free career guides for your professional advancement and survival to avoid burnout. Check out chuckgmd.gumroad.com and some sneak peeks at chuckgmd.substack.com. Check us out on Apple Podcasts and Spotify, and audio-only episodes on YouTube. Until next time, be well and stay curious.